Good morning to everyone. First of all, I'd like to thank the organizing committee for inviting me to speak this morning at the 12th Fora Cardiologia of the section of Cardiology Makati Medical Center. The topic I am assigned to talk on today is the expanding role of ARNI in heart failure, angiotensin receptor nephrilysine inhibitor, clinical application of trial data. I have nothing to disclose. So heart failure is a common clinical condition. In fact, as of prevalence, approximately 1 to 2% of adults in developed countries has heart failure, with a prevalence of more than 10% for patients 70 years old and older. The incidence is 650,000 new cases diagnosed annually in the US, and in the UK, they reported 25 new cases annually. The mortality is as high as 50% for 5 years post-diagnosis of heart failure. We go to the Philippine data. It is said that in 2013, it was pegged that the average length of stay for patients with heart failure is 5 to 9 days. In-hospital mortality is as high as 8.2%. And based on PhilHealth database, for every 1,000 patient claims, 16 of them were secondary to heart failure. Now, these are the different positive outcome trials in heart failure with reduced ejection fraction through the years. As early as 1986 and so forth, you have the ACE inhibitor trial, which is the consensus, the SOLVD. You have beta blocker trial, Copernicus, CIBIS, MRAs, the RALS trials, ARBs, VALHEF, and the other heart failure positive trials. We will center our discussion on ARNI this morning, which is Paradigm HF and other ARNI trials. So just to review, there are basically pillars in the treatment of heart failure, namely RAS blockade, beta blockers, MRAs, novel therapies such as SGLT2 inhibitors. Well, basically, sacubitril/valsartan, which is alone amongst newly proven treatments in heart failure, has been shown to be safe for acute hospitalized settings. It has improved outcomes compared to ACE inhibitors and established data on reverse cardiac remodeling among heart failure with reduced ejection fraction. Again, as a review, in patients with heart failure, there are 3 major neurohormonal systems which are at a dysfunction. Namely, the sympathetic nervous system, where you have vasoconstriction, the increased RAS activity, increased heart rate, increased contractility. The RAS system, or the renin-angiotensin-aldosterone system, where you have increased blood pressure, increased sympathetic tone hypertrophy, and fibrosis. And you have the natriuretic peptides. This one, you produce decreased blood pressure, increased vasodilation, natriuresis, decreased fibrosis, and hypertrophy. A high-risk disease entity needs a complex therapy approach. We all know that for the sympathetic nervous system, we have the beta blockers. For the renin-angiotensin-aldosterone system to block angiotensin 2, we have the ACE inhibitors and the ARBs. And for the natriuretic peptides, nephrilysine degrades the natriuretic peptides into inactive fragments. And the new ARNI, which is sacubitril/valsartan, has sacubitril, which inhibits nephrilysine, enhancing the effect of the natriuretic peptides in the system. Now we go to the Paradigm HF. So in 2014, this study showed that the sacubitril/valsartan significantly reduces death from CV causes or first hospitalization for heart failure compared to enalapril by as much as 20%. In fact, not only that, even investigators reported lesser hospitalizations to patients who were randomized to receive sacubitril/valsartan versus enalapril. In fact, based on the trial, CV hospitalization heart failure is improved, or the relative risk reduction is around 20%. However, in the earlier days, the SOLVD trial, enalapril was compared to placebo. At this point, it is unethical to compare an active drug with a placebo because we all know that based on the SOLD, the consensus trial, enalapril has been proven beneficial for patients with heart failure. So if you do a putative analysis comparing sacubitril/valsartan to placebo, the computation is as follows: 43 for CV and heart failure, CV death and heart failure, 34, 43% for heart failure hospitalization, 28% for all-cause mortality. So that's how big the numbers are. We go to Pioneer HF. Basically, the study is among 881 patients hospitalized for acute decompensated heart failure with ejection fractions less than 40%. What did they do? They measured the NT-proBNP, and the inclusion criteria is for those who have more than 1,600 picograms per ml of NT-proBNP. They were stabilized and randomized to sacubitril/valsartan 200 BID versus enalapril 10 twice a day, and were analyzed for 8 weeks to evaluate NT-proBNP levels, safety and tolerability, and the clinical outcomes. So what were the results? As you can see here, those patients who received sacubitril/valsartan versus enalapril had a significant drop of NT-proBNP. And the graph here in the right shows that the drop in NT-proBNP equated with a significant benefit from CV death and heart failure hospitalization. In fact, be it de novo or new cases of heart failure or worsening chronic heart failure also produce the same result. No? Those patients who received sacubitril/valsartan significantly had a greater drop in their NT-proBNP compared to patients who received enalapril. So what is the conclusion of the Pioneer HF? In patients with acute decompensated heart failure and reduced ejection fraction, the safety and efficacy of sacubitril/valsartan appears consistent. This is among patients with lower dose who did not receive the target dose, which is 200 BID. Whether chronic or de novo heart failure, same results. Similar greater decline of NT-proBNP, reduced heart failure hospitalization, well tolerated, comparable with enalapril in terms of renal insufficiency, hyperkalemia, and symptomatic hypotension. The clinical implications is that these results support in-hospital initiation of SACVAL in stabilized patients with decompensated heart failure and reduced EF irrespective of prior RAS use or prior heart failure diagnosis. Now we go to the 2016 guidelines. Because of this trial in 2014, the algorithm of the European Society of Cardiology has been revised. So this is the algorithm in the treatment of heart failure with reduced ejection fraction. The recommendation is to start them on ACE inhibitors and beta blockers. That's a class 1A recommendation. If after a few weeks they are still symptomatic with EF less than 35, it is recommended to start MRA antagonists such as spironolactone and the like. No? If still symptomatic, then the recommendation is to shift the ACE or the ARB to ARNI, or the angiotensin nephrolysin inhibitor. Of course, other recommendations is if the QRS is wide, you aim for resynchronization therapy. If the heart rate is more than 70, maximize beta blockers, you add ivabradine. If these patients are symptomatic at any time because of congestion, you can give diuretics. And if they have history or symptomatic VTAC or VFib, then implantation of ICD is recommended. If after all this, the patient remains symptomatic, recommendation for the attachment of LVAD or heart transplantation. So this is the recommendation in 2016. Going to 2019, again, because of the Paradigm HF trial, consensus recommendations were done. And what are those? Number one, sacubitril/valsartan is recommended as replacement for ACE inhibitors and ARBs to reduce the risk of heart failure hospitalization in ambulatory patients who remain symptomatic despite optimal medical therapy. Also, to initiate sacubitril/valsartan rather than ACE or ARB for patients at risk of hospitalization and decompensated heart failure to avoid starting on other RAS and shifting. So para at the onset, you can start ARNI to prevent or improve the benefits on CV death and heart failure. Okay. So now we go to the transition trial. So what is the transition trial? This is a study to assess the number of patients who can be titrated to the recommended 200 BID dose in 10 weeks randomization. So transition, no? So as you can see here, to evaluate the proportion of patients achieving the target dose of sacubitril valsartan, 200 BID, 10 weeks post-randomization. To see secondary endpoints to see how many would be maintained on 100 BID if they cannot tolerate 200 BID, or to see whether at what dose we can maintain patients on sacubitril valsartan. And lastly, to assess the side effects or adverse effects that would warrant discontinuation. It's a this is the distribution of the trial. So as you can see, it's a multi-center trial from 19 countries, 156 sites. So this is the study. No, patients were randomized to receive sacubitril valsartan 50 twice a day, all the way titrated to 200 BID. So these are the results. More than 50% of patients achieve 200 BID. Okay? Around 68% reach 100 twice a day, and around 86% were maintained on sacubitril valsartan at a lower dose, but were able to tolerate the medication. Only around 4.5% had discontinuation secondary to adverse events. That includes hypotension. So as a conclusion of the transition trial, number one, it is comparable proportions of patients that met the primary and secondary points, pre-discharge and initiation. About half of the patients reached the maximal dose or the recommended dose of 200 BID. 86% of patients receiving sacubitril valsartan maintained the said medication without disruption in 10 weeks. And the incidence of adverse effects was similar in comparison to the other initiation groups. Now we go to the PROVE-HF. No? So basically these two newer trials, the transition and the PROVE, are after the landmark trial, which is basically Paradigm-HF. What did PROVE wanted to do? No? The PROVE-HF basically is a 52-week multi-center open-label single-arm trial. So there was no comparison from any other medication. So it was sacubitril valsartan started at 50 BID to titrated to 200 BID given at 12 months or a year. And they would like to assess changes in the echo parameters. So these were the goals of the study. Correlation between change in NT-proBNP, 12 months, changes in LV ejection fraction, end-diastolic volume, systolic volume, left atrial volume index. Secondary endpoints would be the clinical parameters such as new onset heart failure, changes in natriuretic peptides. So these are the results. As you can see, as early as 2 weeks, there is a significant drop in the proBNP, NT-proBNP, and it was sustained throughout the 12-month trial. In terms of cardiac remodeling, there is a significant decrease in the left atrial volume index, sustained or continuously decreasing at 12 months. Ejection fraction, in fact, in 25% of patients, there is an observed increase in ejection fraction by as much as 13% at 12 months. And again, compared to baseline LV end-diastolic volume and LV end-systolic volume, as much as 12 ml per meter squared was observed for those patients who received sacubitril valsartan at 12 months. In fact, death or heart failure hospitalization was significantly lower for those patients who have a significant drop in their NT-proBNP and improved ejection fraction by 6 months. So as a conclusion to PROVE-HF, in this study, patients with heart failure reduced ejection fraction treated with sacubitril valsartan has a significant reduction in NT-proBNP, and was significantly associated with reverse cardiac remodeling, as was seen in the 2D echo findings. The degree of remodeling demonstrated may help to explain how sacubital valsartan reduces morbidity and mortality in patients with reduced heart failure. Analysis on the impact of sacubital valsartan in terms of quality of life and mechanistic biomarkers are underway. So basically, when you said underway, it's the next trial. So the next trial is evaluate HF. Remember, Improve HF is a single-arm trial. They did not compare sacubital valsartan with any other medications in terms of improvement of a patient with reduced heart failure in a year's time. This time, they compared improvement with enalapril. So the background, heart failure, reduced ejection fraction, ARNI, reduces death and heart failure in hospitalized patient. That's basically the paradigm trial. This one is comparing it in outpatients, and to see how it works in terms of reduction in echo parameters. So evaluate HF is designed to determine whether treatment of heart failure with sacubital improves central aortic stiffness and cardiac remodeling compared to enalapril. This is the study design, randomization between sac-valve versus enalapril to the echo parameter at day 1, at day week 10, and at the end of the study after around 20 weeks. So in terms of change in the aortic stiffness, there was no significant difference between the sacubital valsartan and the enalapril group, that is at 12 weeks. But in terms of LV end-diastolic volume index, LV end-systolic volume index, there is a significant benefit or decrease in size for those who receive sac-valve versus enalapril. And another thing that was not assessed before was the self of well-being, the assessment in betterment in quality of life. The KCCQ-12 or the Kansas City Cardiomyopathy Questionnaire was also included in this study, and it showed a significant benefit for those who receive sacubital valsartan versus enalapril. Significant improvement in quality of life. As you can see here, the decrease in NT-proBNP equated to an improvement in the echo parameters and the quality of life using the KCCQ questionnaire. So as a conclusion to evaluate, among patients with reduced ejection fraction, sacubital valsartan did not reduce central aortic stiffness at 12 weeks significantly. However, reductions were seen with sacubital valsartan in terms of left atrial volume indices, LV ejection fraction, and other biomarkers. And most importantly, there is a significant improvement in the overall quality of life for patients who receive sacubital valsartan. Now we go to another study altogether. Remember, all those studies were about sacubital valsartan and reduced ejection fraction. Here, they're more aggressive. This is preserved ejection fraction. So using ARNI in preserved ejection fraction, which is the Paragon heart failure trial. So basically, again, this time it's ARNI or sacubital valsartan was compared to valsartan. It's 35-month study randomizing sac-valve versus valsartan 160 BID. Again, to assess primary endpoint, CV death and heart failure, secondary endpoints, quality of life, improvement in the NYHA classification, and other side effect parameters, adverse effects. Again, it's a global trial. More than 10,000 patients were assessed. In fact, the Philippines was able to contribute 33 patients in this huge trial. So more than 10,000 patients screened. Eventually, more than 4,000 were randomized to sacubital valsartan, 2,407 patients versus valsartan 160 BID, 1,389 patients. So what were the results? As you can see here, in terms of primary endpoint, which is CV death and hospitalization, there is a tendency to benefit with sacubital valsartan, but it did not reach statistical significance. Here you can see event rates for death for sacubital valsartan slightly lower, no? Valsartan 797, but again, it is not statistically different. Same with CV death. So the conclusion of the Paragon HF is that in patients with heart failure and preserved ejection fraction, sacubital valsartan versus valsartan had a modest non-significant reduction of 13% in the primary outcome, which is CV death and heart failure hospitalization. Several sensitivity analyses, second analysis, improvement in various measures such as quality of life, renal function, which suggests that it is just comparable with valsartan. And that the use of ARNI, which is felt not necessary, not because of the standard of care in this population, treatment for heart failure with preserved ejection fraction has really no proven standard yet. The data suggests that the treatment response will provide greater benefit for those patients who have lower EF. Remember, preserved ejection fraction is anything more than 45%. So the benefit would be for those with lower EF and with women. Now, there is a parameter study. The parameter study is to compare ARNI with an ARB, olmesartan, in measuring arterial stiffness in the elderly. This is about blood pressure. Multi-center, double-blind, randomized control trial using sacubital valsartan versus olmesartan in controlling central aortic pressure, systolic hypertension, and pulse pressure. It demonstrated superiority of sacubital valsartan versus olmesartan in reducing clinic, ambulatory, central aortic, brachial blood pressure in treating systolic hypertension among elderly. So it's a stronger or more efficacious antihypertensive. Now, there is another trial ongoing. We use RAS blockers for hypertension. We use RAS blockers in MI. And this is to see other venues where we can use ARNI, or sacubital valsartan. This is a study comparing sacubital valsartan to enalapril, titrated to 200 BID and 5 BID in patients post-acute MI. So the trial is to randomize patients with acute MI 12 hours to 7 days in between randomization. Ejection fraction should be decreased by 40% and lower, but hemodynamically stable. Well, it's still an ongoing trial, and it's expected to be completed by May 17, 2021. As a summary, number one, Paradigm HF signaled significant benefit with heart failure and reduced ejection fraction, favoring sacubital valsartan versus enalapril, as much as 20% reduction in CV death and heart failure hospitalization. In fact, putative analysis showed that as much as 36% and 43% reduction in CV death and heart failure, respectively. Pioneer HF showed a significant decline in biomarkers, NT-proBNP, for patients who received sacubital valsartan versus enalapril, which translated into clinical best benefits. These are in-hospital parameters. Transition showed that after discharge, up to 86% patients who were enrolled were able to tolerate sacubital valsartan 10 weeks in comparison to enalapril, and with the same adverse events, similar adverse events. PROVE-HF, which is a single-arm trial, showed significant improvement with 2D echo parameters using ARNI in terms of LVEF and systolic volume index and diastolic volume index, left atrial volume index at 1-year treatment with sacubital valsartan. Evaluate HF compared ARNI and enalapril in improving an aortic stiffness. Though there is a tendency to improvement, there is no significant difference between ARNI and enalapril in aortic stiffness. However, in terms of improvement in ejection fraction and systolic volume index and diastolic volume index and left atrial volume index, there is a benefit with ARNI. Paragon HF, with regards to preserved ejection fraction, showed that there is no significant benefit, or just the same. ARNI with valsartan in patients with preserved EF in terms of CV death and hospitalization. Although there is a tendency to benefit, it did not reach statistical significance. Possible benefit for those patients with a lower ejection fraction and with women. parameters showed that BP lowering efficacy and effect is superior in ARNI versus olmesartan. While Paradise MI is an ongoing study on sacubitril valsartan with acute myocardial infarction. I think that's the last slide. Thank you for your listening and attention. Thank you.
Thank you so much, Dr. Raynato Kasilag. That was a very extensive review on the different trials with ARNI and comparing it with your RAS blockers, ACE and ARBs. At this point, we will open now the 5-minute Q&A. I could see one question posted on the Q&A box. This is from Dr. Philip Jairus Sayo. The question is, can we use Entresto for those patients who have cardiomyopathy but with preserved ejection fraction?
Okay, good morning. Thank you for that question. As we've said earlier, there is a study, which is the Paragon HF trial, which compared sacubitril valsartan to valsartan. In fact, all of the positive trials for sacubitril valsartan was initially on patients with reduced ejection fraction. Paragon is different because this time it compared sacubitril valsartan versus valsartan in preserved ejection fraction. Well, the results show that there is a mild improvement compared to valsartan. So if the question is whether we can use sacubitril valsartan in preserved, probably, but there is no significant difference. So there is no additional benefit if we use sacubitril valsartan versus valsartan for patients with preserved ejection fraction. It's just the same. But in terms of whether we can use it, yes. But would it be better than the present management that we have? As I said earlier, there is really no proven standard of therapy for preserved ejection fractions. So it is a clinical decision, but there is no disadvantage. In fact, if you look at it from a half-empty, half-filled glass, it is as good as the existing treatments that we give.
Thank you, Dr. Kasilag. I think my co-moderator, Dr. Melissa, has a question for you as well.
Hello, Dr. Kasilag.
Morning, Melissa.
Good morning. Congratulations on your lecture.
Thank you.
I have a practical question, sir. Can sacubitril valsartan be effective across all types of cardiomyopathy?
Well, as I said earlier, we know for a fact that in the reduced ejection fraction patients, it was the, shall we say, grand news in 2014 that was presented, because across the board, there is significant decrease in CV death and heart failure hospitalizations. For patients who were randomized to give sacubitril valsartan, that's why all the algorithms in 2016 and after were changed. But again, the only proof is that it is superior with right now accepted therapy of ACE and RAS blockers to cardiomyopathy of decreased ejection fraction. That is whether ischemic or non-ischemic. But in terms of preserved ejection fraction, we can use it. There is no disadvantage, but there is no significant advantage in those types of patients.
Thank you, sir.
I think there is one more question posted here. I don't know if this came from Dr. Jolan Las. The question is, has sacubitril been added to any other ACE or ARB in any trial? And what was the outcome? Was there ever a trial that combined?
We are not aware of that. We all know that sacubitril is a proprietary medicine of Novartis. So as of now, I think it's still under protection. So basically, the combination is sacubitril valsartan. But the study that were conducted earlier, that sacubitril alone will not work without the attachment of the ARB. Because if you suppress or inhibit neprilysin, there will be an overwhelming response to the production of angiotensin II. So it wouldn't be effective. So definitely, it has to be paired with an ARB for it to work. As to the availability of other ARBs attached to sacubitril, I am not aware of it, and I don't think right now it will be available until probably it has lapsed into patency. Its patency.
Okay, I think there is a question from Dr. Eleanor Lopez. Maybe we could entertain this as the last question for the session. Is the dose adjustment of the drug necessary for patients with CKD?
Technically, doctor, if you think about it, those patients who were included in the trial did not include patients who have CKD. But this is just my opinion. No? The trials that were done all intended to reach the targeted goal of 200 twice a day. That is why there is a transition trial which showed that 86%, although it's a good number, were maintained on sacubitril valsartan at any level. There is a significant number as well who were not able to tolerate the 200 twice a day recommended dose. It is stronger, as we said earlier in one of the trials, the parameter trial, it is a stronger antihypertensive compared to an ordinary valsartan in that it has yung neprilysin inhibitor where you promote neprilysin, which also induces diuresis. So it is definitely in terms of blood pressure effect, it is a lot stronger. Now, in terms of patients with kidney problems, as we do with ARBs, no, we usually withhold them for patients with creatinine clearances of less than 30%. So I would like to think that it would still need further studies in terms of CKDs as they were not really included in the trials that were presented.
Okay, thank you, Dr. Kasilag. I think there are two other questions on the Q&A box, but also pertaining to one on acute kidney injury and one on chronic kidney disease on hemo or peritoneal dialysis with the use of sacubitril valsartan. But since we have run out of time,
Just to answer lang, Edwin, they
Yes,
were not
go ahead.
included in the studies. They were
Okay.
these were exclusion criteria. So it would probably need relatively sacubitril valsartan is a new medicine. As we said in 2014, the name is LCZ 696. Parang Formula 44. By 2016, class 1A for heart failure. So parang meteoric rise. And definitely, it would need more trials to potentiate or to provide proof on the different aspects that we would want to use them for.
okay. Thank you so much, Dr. Kasilag.